Welcome, everyone. Thank you for coming. This is a terrific group, a very distinguished group of people. I'm very excited to have everybody here for this is our second Ask Me Anything, and I am just going to briefly introduce our speaker today, and that's Dr. Yogi Matharu. Dr. Matharu is a graduate of USC's DPT program. He graduated in the first DPT class in 1998. He also has an MBA from USC. He joined our faculty practice in 2000, and one of my most brilliant moves as chair was to appoint him as director of the practice that we have on the health science campus. He's been instrumental in developing that practice. In 2016, he took over directing our entire faculty practice, including several practice sites. And since 2021, he's been associate chair for clinical services. He's also had a very important role in developing our residency programs, and in particular our orthopedic residency. So I'm going to hand it over to Dr. Matharu. First, I'd like to introduce Anthony Wallace, who's my assistant, and he's going to be moderating this session. And also Dr. Robin Howard, who's associate chair for operations and finance, who's going to be helping out as well, perhaps managing some of the questions that may come up in the chat. But without further ado, let me turn it over to Yogi.
Excellent. Thank you. Are you still seeing my screen? It seems to show that I've lost that. Okay,
no.
Very good. All right, well, thank you. Welcome, everyone. I look forward to talking about our faculty practice. Dr. Gordon's already introduced my history, but I want to share a personal note. The faculty practice at USC is a very personal issue to me. It's had a lot of impact on my life. I've been there as a patient, a student, a resident, and as a faculty member. So I think I look at it from every one of those viewpoints. So as we describe this practice, I want to outline my perspective. So today we're going to share with you why we do it, how we do it. We're not going to try to say everyone should do it this way, or even say that everyone needs to have a practice. Our primary focus is we want to provide excellent patient-centered and ethical care. This is really non-negotiable to us. That's the central tenet. We are committed to demonstrating to our students, the community, and our healthcare partners that we can be financially viable, we can be compliant and evidence-based. That said, we're not doing it to be a revenue center for the division. This is really driven by mission, not a profit motive. We're committed to being a place where people can get better. That means our patients, our volunteers, our students, employees, colleagues. One of the big questions people are going to think about is our faculty are dedicated to the activity that they're in while they're doing. While they're teaching, they're focused on their teaching. When they're in the clinic, they're in the clinic. And then finally, our practice is aspirational. We're a work in progress, and we openly acknowledge that we don't have everything figured out or everything right yet. And that'll be some time to talk about at the end. But before I go further, and before I start answering any questions, I want to show you a little bit about our practice so that we have a little context of what we're doing. So we're a unique integration in a way that our clinical care, our education, and our research clinical faculty can move back and forth between our sites. We have a large practice, 88,578 patients in the last fiscal year. A little more than half of those are outpatient. Because we have such a strong academic model for our specialty practice, our PTs are similar. We have 74 faculty, and 74% or 70% of those, are board certified specialists. We're going to talk a little bit about our residencies. Our residency programs are a big piece of what we do. We have 7 residencies and 3 fellowships with 29 total. And we have 35 faculty who are actively participating in research and teaching. And we've got some innovations. We've been very lucky to be involved as primary care providers at the Student Health Center, in the Keck School of Medicine, and in the Kaufman School of Dance. We also are doing on-field and performance coverage, some health and wellness activities for club sports and athletic medicine. So I think that just gives you a real quick snapshot of what I want to describe. And so what we're going to do today, let me see, here we go. We're going to go through some common questions, some of the questions that you guys have sent us, and then we'll do an open question and answer. The common questions I'm going to talk about are here, are listed here, and I'll go through them individually. The questions that you all asked, we received a lot of questions on a number of topics. They're mostly focused on things like collaboration, commitment of the university, our faculty, our students, some of our financial operations, and some of you asked for me to share some major events that shaped our model. So we'll go through all of that. So let's start with the most simple question that I think we spend a lot of time thinking about, is why does USC have a faculty practice? And I would say that the why has changed a lot over the 34 years that our practice has been in place. The practice we have now is not what we had in '89, and the practice has grown in the context of what's happening, in our school, what happens in the profession, our health system, and even in our community and what our community needs. We'd love to tell you that all of this was done by design, but the truth is sometimes we've been visionary, sometimes we're just reacting to the opportunities that present themselves. So in order to explain why we have a practice, let me share a little of our history and those key moments that got us to where we are. Okay, so there have been some extraordinary events in our history. The black here on the timeline talks about us before our practices. Then this blue is really where our practices sort of began. And then in the highlighted yellow is really the practice that I would say we are in now. So the first portion in 1984, we had our first PhD. This really marked our division's commitment to the science of physical therapy and really advancing that as part of our clinical practice. Soon afterwards, in 1989, the outpatient faculty practice opened as a separate nonprofit corporation. The term is fitting because it didn't make a profit. Helen's Hislop goal was to have access to high quality clinical faculty for teaching. Having a practice was going to ensure that those teaching faculty were current, and it would improve the ability to recruit high quality teachers. The practice was very small, one part-time PT in one room shared with a pain medicine physician. Then in 1991, USC partnered with Tenet Healthcare to open University Hospital. There was a need for physical therapists, so again, faculty provided that care. The relationship was not easy, it was challenging. We didn't have full control of the care delivery. The goals weren't aligned. They had a profit motive, not an education or a research motive. Then in 1993, on our University Park campus, the students couldn't get access to PT, so the faculty responded. We opened a small space on campus to see students, and then at night, we started treating faculty and staff. The idea here was now we had a practice on each campus. Then in 1998, big changes. We graduated our first DPT class and started our orthopedic residency program. This is really key in my mind in that the specialization and co-education with medical residents, it really created a venue for us to really access the health system, to be interdisciplinary partners in research and education. The physicians that we were working with began to recognize the value of quality physical therapy, and they began increasingly referring only to DPTs with board certification. The idea of residency was really, and clinical development in that form was very familiar to the physicians, and they really took to that. So both the DPT degree and the residencies made our colleagues look at PT with a fresh point of view. So referrals to PT started increasing, and we saw there was an opportunity. Now, 2000 is really our key fundamental paradigm shift in the practice. At that time, Jim Gordon assembled a leadership team, and he committed to growing a faculty practice, but he gave us a few stipulations. He says the practice had to be a showcase for excellence in evidence-based care, innovation, and also specialty program development. The model would not compromise the quality of patient care and would be financially viable. This was his foundational requirement. If we couldn't demonstrate to the students that we could run an ethical, evidence-based PT practice that could make money, we should not be teaching students. The clinics on both campus sites were only seeing about 200 visits per week at that time. So both of our clinics moved to larger spaces, and we've really taken off since that time. Our next big moment was in 2009, when USC purchased University Hospital and adjacent Norris Cancer Hospital. That was a total of 471 beds. They bought it from Tenet Healthcare, which ended this disputed control over the hospitals. The hospitals remained a separate entity, but now the leadership of the PT department was with our PT department. So for the first time, all PT clinical services, hospital and private practice, were run by our division. We then have, in 2012, the acute rehab unit opened, which again, being PTs, we know that a rehab unit opens significant opportunities for education and research. Then in 2013, two big events. USC purchased Verdugo Hills Hospital, making Keck Medicine a true health system with multiple hospitals. In the Engelman Student Health Center building, we were able to rent significantly more space, and we were able to meet the needs of a growing on-campus population. And then in 2022, USC purchased Arcadia Hospital. Now the university has 4 hospitals, but this is after COVID. Our profits are down, discharges are increasingly complex, so there's a high demand for high quality PTs, a demand for generalist PTs, and an opportunity for us to demonstrate how we can add value to the research and education missions by being integrated into our health system. So in summary, our why has changed and expanded. As I said, initially just to recruit clinical faculty for teaching in our master's program, then to demonstrate that we could operate a high quality, viable practice, then as a venue for clinical research to advance our clinics and divisions efforts in our research and education and practice. And over the last few years, it's been a lot more to expand the access to quality PT. We do that by training excellent clinicians and specialists. We partner with the community and in general, try to demonstrate how PT can add value by being integrated. Okay, now what I'm going to do is move to our next question. And that is, how do we integrate our research and education with the practice? And how does that create a great educational experience? So to answer that question, it's important for us to think about the entire vision, mission, and objectives for our division. We're structured in a way that breaks down the silos between our DPT program, our biokinesiology program, and clinical programs. And let me go through that in just a second here and show how that permeates in our community of practice. Sorry, here we go. Yeah. So sorry about that. So the excellence in our clinical practice, such as clinical expertise, interprofessional collaborations, professional service, we carry that to our students during clinical affiliations, as well as through didactic teaching in the classroom. The faculty who are participating, the clinical faculty in the classroom discussions, they learn new concepts, they deepen their understanding, they form relationships with the research faculty that enables more collaborations and development of our clinical questions. The faculty then bring these experiences back to the clinic where they can share this information with colleagues. For example, we do grand rounds, we do some in-services, we do a lot of journal club kind of activity, and then they implement those improvements. This ensures that we have a learning community where the people are participating in research, education, and practice, and they all share the same common purpose. And that is to create a physical therapist who's an expert clinician, a lifelong learner, and someone who values research and evidence to inform their practice. They have to be able to integrate all of this to provide value to their patients, the health system, to their employer, to their profession, and to themselves. So now I'm going to go through a little bit of explaining why clinical faculty are involved in more than just direct patient care. Full-time faculty in our system are exempt, non-tenure track faculty. They're given a Spitzer profile according to their responsibilities. How we do this is in the first year, they're typically 100% service and practice. Our new clinicians focus on developing clinical skills, efficiency, documentation, developing relationships, all the things we need to be successful in the clinic. Then in year one, they're expected to take a APTA CI credentialing course. After year two, most of them are expected to begin clinical teaching as a CI for a minimum of 10 weeks per year. Their profile shifts. It typically moves to 90% service and 5% scholarly and 5% teaching. As they progress in their skill development, they may begin participating in labs, then as testers, eventually working up to larger roles in teaching. Some faculty seek further development in other areas, such as research or leadership. Their faculty profiles will reflect these changes over time. Productivity, while they're in the clinic, they're expected to meet the normal standards of a typical clinic. At the end of the year, each faculty member submits a merit review outlining their activities. All of our full-time faculty, regardless of whether they're clinical, research, or teaching faculty, are reviewed by a peer review committee, and they use the same merit review guidelines that include criteria for research, teaching, and clinical activity. Unless they've demonstrated experience elsewhere, most clinical faculty are hired as an instructor of clinical physical therapy. When they seek promotion, they're promoted through a practitioner track. All right, so how do we do this? It sounds difficult, and it is. It actually requires a lot of coordination. I'm going to describe our division level clinical management team that makes this possible. So here are our clinic directors. They manage their locations, their sites, and they have regular meetings with their faculty, staff, and residents. 3 of the 6 here are also leaders of our PT residency and fellowship programs at USC. This group here on this slide, plus the clinic directors on the previous slide, are members of this team. They represent division operations, the DPT program, outcomes research, and clinical services. We meet on a monthly basis to review the activity of clinical faculty who are in research or teaching. In this meeting, we discuss the teaching needs, the performance of the faculty member in the classroom and in the clinic, and we discuss requests for release time for research. So let me describe that a little further. So Julie and Monica identify opportunities or openings in the classroom or in immersions. They send that out to all of the faculty, who then can express their interests. The eligible candidates, we get together and we talk about the course requirements and the candidates. We look at the person's goals, their experience, their status of development, and whether the clinic can afford to accommodate release time to get back over to the clinic, to the teaching, and our patients are still getting what they need. If the release time can be accommodated, then the faculty member meets with the course leadership to see if there's a mutual interest. We always try to grant release time if possible. The faculty member participates in the course, and then the committee monitors the progress. The key here is the course director, the faculty member, the clinic director, they're all aware of the release time and of the expectations. For research, Lori Michener is the director of clinical outcomes and research. She mentors our faculty regarding opportunities to participate in existing research projects throughout the division. When a faculty member has their own idea for a project or a presentation or a poster, they work with her to write a request for release time that includes the goals of the project and timelines. Lori presents this request to our committee, and again, the when there's an approval, the faculty member and everyone on the committee, including the clinic director, is aware of this arrangement. We monitor progress, and every 6 months we renew that approval. So this system for us, what it really did is it ensures that the faculty members have the support they need. They're not placed into positions before they're ready, and they can receive mentoring and faculty development training as needed, because we're able to see how they're doing. Okay, so how does this work? And what are our results? So this slide just gives an example of the 2022 calendar year. We had, in our faculty practice sites, we had 69 students with a combined total of 609 weeks. Now, this isn't everybody. Our DPT program has approximately 900 placements a year, so this is still a small portion. But for us, since the pandemic, we've had an increasingly difficult time placing students in hospital settings, and our own sites give us an opportunity for the students to be exposed to hospital practice. And it's really great for the physicians, the nurses, the occupational therapists, the speech therapists. Everyone can kind of see what a high quality student looks like. It's really important for them to participate in complex care, and Keck Hospital has the highest case mix index in the country. 35 faculty, as I mentioned, are teaching, and they research in 5 different laboratories, and 3 of our faculty are in part of grant-funded studies. This doesn't include the many faculty who participate in guest lectures, lab practicals, and immersions. Our faculty are also involved in teaching in other areas through the university. Most of this is coordinated directly by the faculty member. This teaching broadens the experience of the clinical faculty, and I think it's important that it exposes our profession to other schools, other students, and it tells them about the knowledge of a physical therapist. And it's not a bad recruiting tool either. While teaching and seeing patients, our faculty are also participating in disseminating information through posters, presentations, publications, and of course, they're involved in service as members, chairs, and elected positions in national committees. All right, let me talk about the next question. How does our faculty practice collaborate with local clinics to advance the profession? The simple answer, and it sounds a little flippant, but it really isn't, is we don't compete with them. Rather, we're partnering with clinics in the community, and we try to bring them in and improve their access to our health system, our school, and to our students. There's too many patients in Los Angeles that deserve access to high quality care. We refer patients to each other. We add their names to our health system referral list. We have shared COVID protocols. We've helped hospitals and clinics learn how to manage new conditions and surgeries. And we've helped these programs develop oncology and pelvic health programs. We're very, very lucky. This is a collaborative community of practice. We have relationships partly because of our strong adjunct faculty. They teach at USC and work in community practices or hospitals. But we also have some structured collaboration through our post-professional education program, including residencies, fellowships, and continuing education. So our residency and fellowship programs create opportunities that are both formal and informal through with our clinical sites, I should say. So there are 26 residents and 3 fellows this year. Of these 29, only 13 practice within our USC physical therapy sites. The residency and fellowship programs include several components. There's clinical practice, participating in didactic continuing education, and participating in teaching within our program. All residents participate in didactic modules where they're interacting with other residents, mentors, and community PTs. They also participate in weekly literature reviews. All of this creates a structured opportunity for our clinicians to improve the quality of their care, consult with each other, and present cases. The mentors from these sites talk with each other, and we continue to refine residency education. Through these programs, there's a back and forth exchange of knowledge and between the faculty practice and the community practice. Many of the PTs in these clinics also participate in our continuing education coursework, and they serve as clinical instructors to our students during clinical experiences. We do offer continuing education discounts to our clinical instructors, so it further broadens who comes to our courses. All right. Now, going back to some of the additional questions that people ask related to collaboration and commitment, and really what is our health system. This may seem very simple to some of you, and it may seem a little odd. So there are two entities at USC. First, there's the university proper, and second, there's a separate system, health system. The health system is owned by the university, but they have a separate HR process. So in our PT clinic model, all clinic faculty and staff are hired through the academic division in the School of Dentistry within the university. And in the hospital, some of the staff is hired through the hospital HR office, but our PT faculty are brought in using a closed faculty model similar to the physicians in our medical school. The relationship is really that our practice is mutually beneficial to all constituents. The division needs a place for practice, education, and research. Our health system and our interprofessional colleagues need PT's expertise to innovate care, and our patients need clinical service and the development of new treatments. So let me describe our model here for a minute. So we have three different models. In one model, the academic division provides the faculty to Keck Hospital and Norris Cancer Hospitals for inpatient, outpatient, and acute rehab unit. This includes all of the clinical directors that supervise the programs. The leadership negotiates a budget at the hospital on an annual basis, and we manage to that budget. In this model, all new hires are faculty. However, the clinic directors are managing per diem PTs, PTAs, aides, and clerical staff that are hired and paid through the hospital's HR system. Our aides and our PT assistants are part of a union. In our second model, we operate similar to a traditional private practice. We bill our outpatient services using the tax ID of the USC Care Medical Group and utilize their contracts. This is really our riskiest model. We have the most control here, but are responsible for all expenses, HR, and compliance programs. And then in our third model, we've been exploring a lot of things to diversify how we do things and to better serve our university. So in this case, we provide services to other departments in the university. We negotiate payments on an hourly pass-through or management agreement. What isn't entirely clear from these images is that we're in a really unique position, because across this continuum, the academic unit is overseeing care across all settings, from pre-injury to outpatient to inpatient and back to outpatient care. We don't have home health within our system at this point. Now, because we're delivering care at a quaternary medical center and we're known for multiple specialty care programs, we do these specialties listed here in both our outpatient and inpatient settings. These really form the core reasons why patients and referral sources seek out care at our clinics. Some people asked about, well, what are the collaborations that we're involved in? We're involved in a number of interprofessional clinics providing care to patients. Some of these are listed here. We've already spoken a bit about our residencies and our residents in the physician clinics. During their residency program, they see patients on a weekly basis with physicians. This creates opportunities for our residents, the MD residents, the physicians, and other disciplines that pass through the clinics. This really advances our profession because the physicians can experience firsthand the value that a PT brings to patients. Because of this collaboration, they develop a relationship with the residents as well as a local PT clinic where that resident may be placed. Once the physician knows how to better identify high quality PT, they tend to promote clinics that produce better outcomes and better patient satisfaction. This in turn encourages the clinics to better manage their outcomes. As we don't have the capacity to hire all of our residents, they're usually hired by local clinics and spread out through the community. This further expands the physicians' network of high quality practices. Our physicians actually welcome the residents in their clinics because PTs become good referral sources for surgeons. And many of these relationships go on to become research relationships too. We're also involved in managing a lot of the risk and quality issues that at our hospital, including things like representing our hospital during the Department of Public Health investigations. We're assisting with analyzing discharge data to improve outcomes, discharge, disposition, and readmission. Our goal here is really to show that PT is a solution, and maybe they haven't thought about us in the right ways if they only think of us as part of patient care. All right, I'm going quickly here so we can get to questions. So additional questions that people asked were related to the details of our faculty and our people. Some people asked, this seems like a very busy slide. The intention here is to really describe for a second how our employment arrangements work. Some people asked, do you have non-faculty treating patients? So this gold here represents people hired through our academic division's HR. The blue shows the hospital and partner settings. As you see, only faculty and residents treat patients in our private practice areas. In the hospital, our leadership and a majority of our clinicians are faculty. We do have a few staff PTs in our hospital. Now, when we look at the staff in the hospital versus the faculty, we don't distinguish between them when establishing targets for productivity. A little more on that, our clinicians have the autonomy to schedule the time they need for our patients. In general, inpatient visits are about 45 minutes. In general, the outpatient evaluations are about an hour for evaluation. Follow-up are 30 minutes for orthopedic and sports specialties, and some of our more specialties like neurologic physical therapy, they tend to be 45-minute follow-ups. But as mentioned, the clinician has full control and can make adjustments as necessary. The clinical faculty are paid an annual salary. They are exempt employees and receive the same rate whether they're teaching or seeing patients, and their income is not directly tied to the number of patients they see or the units they bill. We can talk about that, but that is by design. Now, the financial aspects. This is where I get the most phone calls, and there was quite a few questions related to this. And the answers are not too complicated. So I would say the portion of our faculty practice that is not a salary pass-through, it functions like a traditional private practice, and it has all the same challenges as any other private practice. We outsource our billing, our collections, contracting, and credentialing to the USC Care Medical Group. We would think you'd get a better rate, but our contract rates are about the same as what typical clinics get. And of course, Medicare pays us the same rate as they do everyone else in our region. We manage all other operations, including scheduling, collection of copays, verifying insurance. We don't receive subsidies by the university, and we're responsible for all rent, maintenance, equipment, supplies, staff, and faculty costs. What this means is, because of this, we don't take Medi-Cal or Medicaid, as it may be in your state, nor are we able to take all of the HMOs. However, our hospital practice does take Medi-Cal and most HMOs, and so we have expanded our PT services at the hospital to improve patient access. Some of you asked about pro bono care. Currently, we do not have a pro bono clinic, but through these clinics, we do provide charity care for patients approved by the health system. We also participate in support groups, wellness classes, and multidisciplinary clinics. Our division operates a program called Fit Families that also provides services to the community. And Anthony, maybe you can drop a link to a video on that you guys can all watch later. And then the big question that we always get is, how much money can we make? And so we're a nonprofit organization, so we don't really talk in terms of profit. However, we do talk about surpluses, and we target a 5% surplus per year. We reinvest a lot of that during the year, so we recognize we could probably do better than 5%. And in the last 20 years, there are some years where we've generated over 15%. And during COVID, like everyone else, we lost money because we weren't able to see as many patients. The upside was we had a lot of faculty available for the teaching efforts. All right, I'm almost through with this part. The lessons learned. We should have implemented our division level management team sooner. It was too much to expect a faculty member, especially an inexperienced one, to figure out how to do all of this on their own, even though they had the help of our clinic director. Some of our faculty members were being approached with every opportunity, and they found themselves stretched too thin and unable to prioritize according to their own personal goals. And other faculty members, they weren't even aware opportunities were open. They weren't able to do all the things they wanted. Sometimes we found that multiple faculty were out of the clinic on the same day, making it really difficult to manage patient care needs. Now our current process makes sure that there's equal access, that there's well-being of the faculty member, and that our patients continue to have access to the care they need. Another big lesson that I think of is we should not have tried to restrict teaching duties in artificial ways. Seeing patients is really difficult. Teaching is also difficult, and it's easy for people to feel overwhelmed. So in response to that, of people feeling overcommitted, we implemented a rule that people should only teach one semester a year. We required that they practice with us for at least 2 years before getting involved in any classroom or lab teaching. The faculty were frustrated. We often had to make exceptions because a lot of people were very skilled and we needed them in places. And it made the decisions seem very random. Now we make suggestions and we mentor faculty, but we don't have any firm rules outside of their actual performance. Other lessons is merit review and promotion guidelines really have to consider clinical non-tenure track faculty. For example, there must be guidelines that include activities that occur in the clinic, clinical practice metrics, program development, clinical teaching to non-PhD students, service on clinic and hospital committees, counting towards service, really fleshing out what a clinical faculty member looks like. All right, and my final thing before we start with open questions is sharing just a little bit about our challenges and the challenges to this model. Some of you have experience with hospitals. Hospital leadership turns over relatively frequently. It's hard to keep relationships maintained. So we keep our presentations handy and sharp, and we speak to our leaders often. Our clinical partners are a little bit easier because they tend to stay at the university longer. Sometimes the needs of the faculty member, the DPT program, and the clinic are hard to manage within one person. I think that takes a lot of mentoring, takes a lot of thinking, and it's a lot of effort. And then the one that many of you will be hit by is that fee-for-service is getting harder. Value-based care is where PT is going to shine, but it still seems to be a long ways off. Okay, with that, I'm going to stop sharing and I'm going to open to questions. And what we can do is you can drop questions in the chat, but otherwise just raise your hand and Anthony will help me locate you. You can go ahead and unmute and speak. Yeah, I see a question from Scott. Is the business side of things taught to students as well as the clinical? And for us, yes. Actually, I am the co-director of a course that teaches healthcare systems and talks about all of these issues that we've been sharing. It's really critical, and it's a personal belief of mine. We've worked with our private practice section quite a bit to develop a curriculum for this business cases. And the issue is, if a PT is going to be successful, they have to understand how they provide value. How they provide value is to the patient, of course, but what students often tell us is it's really hard for me to figure out how to meet the clinical demands that our clinic director is asking for, and how do we mesh that with really creating the best quality for patients and the evidence base that you've taught us. And I think that we spend a lot of time showing people how do you navigate that. And again, our practice is really a big way that we have people who know that and can speak to that on a daily basis.
Dr. Gorman?
Yes, thank you.
Yogi, great job. Just a couple questions focusing on financing. You kept emphasizing nonprofit and saying nonprofit didn't make a profit, but then you clarified later of surplus. Clearly, Dr. Gordon charged you to be sustainable. So, profit means sustainability sometimes and what we do with the profits. But two questions. One, how do you compensate faculty above and beyond their university salary for working in the clinic? And when you said you lost money during the pandemic, who lost money? Was it the faculty practice itself, or was it the university and carried you through? How did you manage those losses during that time? Thanks.
Okay, so two great questions. So the first one was about nonprofit, right? So yes, we are sustainable. Yes, we do target having a surplus. And then I think I got fixated on the second part. So if I missed something there, bring me back to it. But the second part is who lost money. All of this is contained within our academic division. So you are right. When you lose money, we do lose money within the division, and we try not to do that very often. I hope COVID is a once in a generation event, and it won't happen to us again. Yeah, and I can go into more detail on that.
In the middle was my more important question. How do you compensate faculty above and beyond their salary?
Yeah, we don't. What we tend to do is the way our faculty are hired. We generally hire them to be in the clinic, and some of them who've got some experience or have been teaching with us already will come in with a part-time in the clinic, but also have time in the academic division, and they're paid a salary, and their effort is moved depending on where they are functioning. So no, it's not above and beyond. There are cases where people will do above and beyond, and we do overloads, but generally that's not our primary model. Our primary model is everyone's a salaried faculty member.
Dr. McMenamin.
Yes, good afternoon, everybody, or good afternoon here from Chicago. I'm at Northwestern. And first of all, I want to thank Jim Gordon for inviting me to join this presentation. This has been an outstanding presentation. I really appreciate it, especially given the fact that we at Northwestern, after working on it for 13 years, just got fully integrated into the Northwestern medicine system for education, research, and practice. So this has been enlightening, and thank you very much, Yogi, for sharing your experience with this. My question is, in terms of the oversight, you mentioned it sounds like the PT school has oversight over all PT in the 3 hospitals and the clinics. And correct me if I'm wrong, but going along with that, did I understand it correctly that the staff PTs in the hospitals are not faculty members, but the managers and directors are? Is that how that works?
Yeah, I want to just clarify. We're actually overseeing 2 hospitals at this point. We're not into the newer ones yet. The staff PTs that remain in the hospital are per diem staff, as well as some of our legacy staff who were hired before we moved to a full faculty model. So the majority of our clinicians in our hospital settings are faculty. I think we have 3 per diem and 3 staff PTs right now. All new people that we hire are hired as faculty. And
that's very unique and very impressive. And is that's true for the clinics also?
In the clinics, everyone is faculty or a resident. Our residents are staff, but otherwise everyone is faculty. And all of our support staff in our practices are hired through our department as well.
Thank you very much.
Sure.
Dr. Top.
Yeah, I want to echo what everybody has said. Thank you. This is an outstanding presentation, and I loved seeing the history of how long it's taken to get to this point and the drivers along the way. It's kind of similar to what we've done at UCSF, so a lot of parallel processes there. I'm wondering whether you have a specialist on the team who is a specialist in informatics and how you use informatics to decide on how to expand clinics, how many students you need, whether students are getting, students and residents are getting an understanding of outcomes, patient outcomes, those kinds of things.
So I'll answer that in two ways. One is we're all over it, and then the real answer is, this has been our hardest challenge. We spend a lot of time on performance indexes, and we several of us in our group are members of our private practice section. We spend a lot of energy looking at what are the metrics that other groups use. How do we really excel in clinical practice? We're involved in multiple computer systems. We have our hospital systems, we have our private practice systems, and then our billing systems are totally separate because our university has compliance requirements around that. So pulling all the data together and making sense of it is a big task. I would say some of our systems give us nice reports. No system gives us all of the data together in one report. So we spend a lot of time with Excel and pivot tables, and I would confess that we've got a number of folks working on data analytics with us, and we're probably not where we want to be. We see the value of it, and we're trying to invest in that, but we're not where I think we could be and will be in a few years.
We have a question in the chat from Dr. Patterson. Can you describe the events that contributed to the transition to an integrated model? Most clinical leaders do not easily give up control of the clinical services.
Yeah, I think the critical event for USC was, I think, the purchase of the hospital. So when USC purchased the hospital from Tenet Healthcare, I think the opportunity was they didn't have anybody else. They knew that they didn't like how Tenet was running things. So I think it was really just an opportunity, and we really rose to it. Again, a lot of leadership from Jim Gordon and others, and I know we spent some energy with. We heard some presentations from Alan Jetty. He came out and talked to us about system skills, and we spent energy developing that model. So once you have the pitch, and I think when you can show that we can provide high quality but also be sustainable, it's really hard, I think, for a health system to fight it. We can show we can do it well. We can bring in good students. We can add an academic and research mission. USC was very focused on being a top 10 university, and they know the only way to do that is to really integrate the research and education into the mix. So I think it was an easier convince. I don't want to make it seem like it's really easy, because this is a conversation that happens almost on a every quarter basis, where we talk about how are we doing it, should we do it, why do we do it, and we've got to stay sharp. And to the point that Dr. Top talked about, we try to really have good presentations and spreadsheets to demonstrate that the way we do it is as good or better than anyone else. So then they aren't tempted to bring in another group.
Can I add something to that, Yogi?
Please.
I mean, Anthony asked an excellent question, and when we talk about the clinical leaders who do not easily give up control of the clinical services, the reality is that often they are physical therapists, and so in many situations there's a level of middle management in which physical therapists, clinic directors, especially in hospitals, are often resistant to academic departments coming in and even just being partners in the clinical practice. So I mean, that's the big barrier that I find a lot of academic centers need to overcome. And it's one that has to be approached with humility, and you just have to work hard to get the trust of the people in those positions. So it's a great question, Anthony.
Dr. McMenamin?
Yeah, two things. First, I totally agree with what Jim Gordon just said. In fact, here at Northwestern, we're right across the street from Northwestern Memorial Hospital, the largest hospital in Illinois. And I worked, when I came on board on the faculty here 13 years ago, I met with the directors of PT there over a period of 6 or 7 years. And it was always not interested, not interested. Oh, we're interested, but too much trouble. And it was finally when a new person came in who understood the value of academic medicine, then things started to change. And so I totally agree with that. I have a question, though, on this model of bringing all clinicians into the system as faculty members. We haven't tried to do that. We're at the beginning of this new relationship, but has that had any impact on turnover? Because traditionally, turnover especially in the acute care environment is very high, or really throughout our profession, it's very high. Is turnover a problem when you're getting these people in as faculty as well as into the hospital system?
Yeah, two questions, I think, there. So how we emphasized why we wanted to do it the way we did it is we patterned after medicine. And in our hospital system, the School of Medicine is separate from the hospital. And our faculty are brought in through a contract and through credentialing. They do that for our county hospital as well. So this was a model that I think they understood. So what we proposed was a closed faculty model. We said, we'll take what you've got, we'll manage all of the staff as well. And then what we'll do is as we bring in new people, they'll all be faculty. So that part has been really no different than I think the onboarding and credentialing and all the things you have to do with all employees. Turnover is a big challenge. And in the hospitals that are not part of our system right now, that are the newer ones, turnover is pretty high. I would say about 2 to 3 years. It seems like they're seeing the staff turnover. I actually think that's a unique part of being a faculty member. What does a clinician want? They want to have mentoring. They want to work in a high quality environment. They want to have the opportunity to mentor and be mentored, and they want to grow. They want to work with complex patients. They want to contribute to the profession. And so a lot of our faculty come to us because they are really interested in the broader profession. And by being in an academic model and by being housed within the academic unit, it's easier to move people back and forth. Whereas I think when we prior to this model, when we had faculty who had to, we had to negotiate every arrangement where, okay, you're going to pay this time or you're not going to pay this time, and it was very difficult with tenant, for example. So I think it does help us with turnover.
Thank you.
Dr. Jard?
Hello, thanks Yogi for your presentation. I wanted to, we brought a faculty practice since 1998, so not quite as long as you, but for a fair amount of time. And we haven't grown as much as you, but I think there are a few intangibles or things that you can't quite quantify that clinical practices offer to academic programs that I know we've spent a lot of time trying to convince administration of the value of our clinical practice. So, for example, I know from an admissions standpoint, when I talk to students and say, you will do your ICE experiences side by side with our faculty who are teaching you in the classroom at the same time, that's really appealing to students, and if that, nets 10 more students or 15 more students, the revenue that's associated with that is tremendous, right? We do a majority of our ICE experiences in our clinical practices, which during the pandemic, I'm assuming it's the same in California as it is in Philadelphia, most places would not take students for ICE. So, a lot of places were stuck with just doing virtual stuff, but we had, our clinical practices, so we could keep doing our ICE experiences and stuff, which was invaluable during that time. We have courses within our curriculum that are tied to our clinical practice. So it's in some regards like a tuition generator as well. So I'm just sort of curious, you know, if you've had other intangibles like that that you've tried to use to really substantiate the value of your clinical practice beyond, you know, making money.
Yeah, I think as I say, to me, the number one thing that I can do for a student who is graduating as a PT is show them how to practice in an honest way, in a way that makes them go home and feel good about themselves, that they provided the highest quality care. But also with the realities of that this is a business. They've got to be able to generate revenue for themselves and for their clinic. So I think that's a key benefit. I also think that the benefits of when you're a faculty, just as you say, when your faculty member comes in and says, this is what happened to me yesterday. This is what happened with this patient. I'm not quite sure how to solve this problem. I needed 8 visits and they got 3. How do I get them back to where they need to go? How do I negotiate that with the insurance company? How do I negotiate that with a physician if that's the barrier? I think those conversations coming in and that mentality coming through, and if you do that with a first-year student, they're thinking about that in every class they take. They're thinking about that in an anatomy class, and they're thinking about, well, when this tissue isn't going to heal in the time frame that we need, then how do we make that argument? So again, I think all of this really comes in, and there are many intangibles. The other is that our students, as you say, want to come to our clinical practices. They want to work at those practices when they graduate. They want to tell others about the spaces. So I think it has huge opportunities for us. And we didn't even talk about the research aspect, and that's another big piece.
Yeah, thank you.
And we have enough time for one more question or comment. Dr. Gorman.
Thank you. I hope I can get this in, keep everybody, on time. But I've just heard for the second or third time this question about profit, and there seems to be a theme about that's not good. And I know, it's weird for me because I don't always share that. But Yogi and I have done some work with the private practice section, which in most cases is all about profit. But I guess what I just want to add is that I don't think profit's a bad thing in these cases. Our faculty practice is much smaller, but we do generate surplus. We pay all our faculty above and beyond their salaries for working in the clinic. And the profit and surplus that's generated, we use in our department. Sometimes funding from the university is diminished over the last few years, and we use that to supplement our budget for buying equipment. We recently bought a diagnostic ultrasound. We also have a program where faculty can apply for additional funds for travel to attend conferences, since our travel budgets have been cut a little bit. So we're proud of the 12 years of our faculty practice. We've generated surplus every year, and we use that income to supplement our school budget, and we're happy and proud to do that. So I think making money on these operations is not a bad thing. Thanks.
Thanks. I would just one last response is I don't want to imply at all that profit is bad. Profit is important. It's important to our profession. It's important to our school. What I really why I keep emphasizing that is that I don't think you're opening a private practice or a hospital practice with the intent of generating lots of revenue to be able to subsidize your program. That's really the emphasis I'm trying to make. Sustainable, not necessarily a separate revenue stream. So thank you. Thanks everyone for coming. I really appreciate it. I'm happy to talk offline. If anyone has any questions, please reach out. Thank you.
Okay, are we ready to go? Good.